I'm very pleased to be here. I'm Laura Michaelis, and among the things I treat in the clinic is myeloproliferative neoplasms. And it's been a real interest of mine, both for clinical education and for research. And I just want to spend a few minutes today talking about why I think if you have the opportunity, you should be considering clinical trials. So the first reason, of course, is that myeloproliferative neoplasms are pretty rare disease. And you can look at this, we look at something called the incidence rate, and you can see that the three major myeloproliferative neoplasms that you hear about, polycythemia vera, essential thrombocythemia, and primary myelofibrosis, occur very rarely. Just compare them, for example, to the incidence here of lung cancer and breast cancer, which are among the most common cancers that affect individuals in the United States and worldwide. So why does that mean you should participate in clinical trials? Well, what that means is that in order to really prove something, I intervene with some new agent or some new exercise program, and that leads to the following result. We need a given number of people to be in those trials, in those experiments. And with this being such a rare condition, finding those people and accruing them on the clinical trials is difficult. And that's one of the reasons, and one of the most important reasons, why patient support groups and advocacy groups like this one have been very important in having us learn in a definitive way whether or not something works. And that's because being in clinical trials is the only way for us to move from anecdote, from, oh, I saw a patient and they did this, to this is what happens when you give 100 people this particular intervention. And that's the essence of clinical trials. So what do we do clinical trials on? Well, of course, we'd love to do clinical trials that might tell you intervention A or intervention B is better at prolonging someone's life. We don't always have the ability to do those, but we do have the ability to test whether or not it impacts on the essential problems that are associated with the diseases that you have. For example, in essential thrombocythemia, we worry, for example, about blood clotting, about heart attacks, or deep venous thrombosis. We worry about side effects. Of course, we worry about symptoms. One of the most amazing things to happen in myeloproliferative neoplasms is a very standardized symptom form, I'm sure many of you have taken it, that's now been accepted by the Food and Drug Administration as a reason to consider the approval of drugs. That's called the MPN SAF. And that is MPNs are one of the most important diseases where actually the symptoms are a reason that drugs get approved and authorized to be used. Transformation, meaning changing from essential thrombocythemia to something like myelofibrosis, is another thing that we'd like to be able to understand better. And clinical trials can be done to ask some of these questions. For example, questions like, who's at risk? How do we control blood counts better? Should we use blood thinners? How do I measure the symptom burden? How do I quantify the disease, for example? So these kind of questions in essential thrombocythemia and polycythemia vera are important, what we call endpoints of clinical trials. In myelofibrosis, the endpoints might be, for example, can we reduce the spleen size? Can we improve fatigue, sweating, itching, for example? Can we improve anemia? So when we're doing clinical trials in diseases like ET, PV, and myelofibrosis, the first thing we need to do is identify what we want to change. And when you're looking at a clinical trial, and we'll talk a little bit more about that, want to think about what is that outcome. So I also want to just point out that women in clinical trials is an incredibly important issue as well. The first thing is because there is differences between the way that women's disease manifests itself and men's disease manifests. We know that there's differences at the age at which they're diagnosed. Now that may be because the disease grows at a different rate or appears at a different time in women. It may also be because women are more likely to be involved in medical care earlier on in their life than men. Many women get a CBC, a complete blood count, when they're pregnant, for example, and that may be the first sign of something. Whereas in a general male in a general male, they don't always get a blood count done as part of just a screening procedure. There may be differences in the rate at which you go from a small amount of disease to a larger amount of disease. I call that clonal expansion. There may be a difference in the natural history, whether or not somebody's more likely to have a clot in their abdomen or a clot in their legs. There may be differences in what their symptoms are. In fact, there are differences in what their symptoms are. So making sure that women are involved in clinical trials means that when those interventions get utilized, when they get approved or made more widespread, we have information on how they work in women, not just in men. And in general, women are really less represented in clinical trials, across all clinical trials, which is something we should change. I just want to point out again that there is differences in how women are diagnosed with all MPNs and essential thrombocythemia, and that changes during the course of their ages as well. We also know that women are more likely to have splenomegaly when they present. They're more likely to have what we call mass erythrocytosis, meaning high red cell burden, but not necessarily that showing up in their complete blood count. They're more likely to present sometimes with clotting that impacts the liver. And the symptom burden differs as well, and that gender influences how this disease, how there's a complication, et cetera. So, as I said, we've found that in surveys, we've found that in retrospective studies. And all this means that if a trial is considered for you, I would argue that you should think about it. We have a lot of things that are left to solve. What are the best agents for curing these diseases? What are the more effective treatments among several? Which ones should we be considering for people? Which treatments are more tolerable? How can I manage my symptoms better? And I would argue that the most important symptom that we don't address very well is fatigue. And then how can we prevent my disease from becoming something that's more aggressive and more more life-threatening? So we discuss this because I think if you're more informed about clinical trials, you're more likely to participate. So we're going to talk a little bit about what a clinical trial is, what the oversight is, when you should consider participating, etc. So you've all heard many times about the fact that clinical trials in this country have not always had the protections that they are now. In the early 1900s, all the way into the mid-1900s, there were examples of people where they conducted clinical trials with inadequate protections for the patients. And that has really led to, since the 1970s, I would say, a large infrastructure that surrounds clinical trials in order to protect patients and make sure that the information that's gathered is valid. So a clinical trial can be preclinical research. That's the kind of trial where a doctor might take some blood from you and then use it in a test tube or in a petri dish to test and see how well a given agent might change the blood cells that you have. That is evidence that's not done, or evidence that's not collected in you, that's collected or worked on in a lab. Maybe if you were to have acute leukemia, somebody might take your blood cells and grow acute leukemia cells in a lab and then do some experiments on those. That is all preclinical. Clinical research is the kind of research that involves an individual who takes or is exposed to an intervention. And that can be early phase all the way to what we call a phase 4. And then sometimes there's also trials that are done once a drug is approved, and those are aftermarket interventions. So the main question that a clinical trial asks is, can an intervention impact an income, or impact an outcome? So does a new pill prevent spleen growth in patients with myelofibrosis? So the intervention would be this new pill, and the outcome would be spleen growth. And so all clinical trials are really eventually asking that question. In phase 1 or early phase trials, it's really all about the intervention. Is it safe for humans? Now, we're not even talking about people with illness, right? We're talking about the very beginning, can humans take this pill and is it safe? And then the next question is that pill safe for people with a given kind of cancer? So if it's safe for people who have no other problems, then we have to test it in people with, for example, myelofibrosis. That's also in the phase 1 testing. Phase 2 testing is where we're asking the question, is there any hint of effectiveness? Is there any hint that it might make a difference? And are there particular side effects or what we call toxicities that happen when they take that pill? That's a phase 2 testing. That is, we're looking for the very first hint that there's an effectiveness to the pill. And then the last question, which is phase 3, is important because what that says is, does this intervention, in this case a pill, work better than what was already available, which is what we typically phrase as the standard of care. So does this pill work better than what you would get if this pill wasn't available? And those are phase 3 studies. Those are mostly randomized, and those are designed to ask, is this new intervention worth bringing forward? Now, there's oversight of clinical trials at all levels, phase 1, phase 2, phase 3, and even phase 4, which is once a pill is approved, how does it work? And these oversight is provided by the Food and Drug Administration. It's provided by the local institutions that's doing those trials. We have IRBs or safety monitoring boards, even within that, so that's the second layer. If the trial is sponsored by a company that might be making that pill or marketing that intervention, they provide an additional level of oversight. And then, in addition, the way that we design trials often provides oversight. For example, if we're testing if this new pill works, is safe to take in people with myelofibrosis, there might be stopping rules, meaning after 3 people are dosed, a committee needs to meet and decide if the safety has the risk-benefit to put the next 3 people on it. So there's different layers of oversight, and all of these layers cooperate to make it to ensure that no one is taking risks that haven't been where there hasn't been a lot of foresight putting into it, and that the people who join those trials are aware of those potential risks. So again, there's different reasons to think about participating, and I would argue that the different kinds of trials, a phase 1 trial, a phase 2 trial, and a phase 3 trial, are appropriate for different groups of people. Phase 1, where you're being exposed to something that's not been used in humans before or not been used in people with myelofibrosis, might be appropriate if you have really exhausted the trials that are otherwise open to you, or that the standard of care is not working for you. Or if it's a phase 1 study where the risks of that agent are not particularly high. Phase 2 and phase 3 studies may be appropriate for you at different times of your disease trajectory. So when you're thinking about a clinical trial and talking with your physician about it, you should be aware, what phase is this? What are the prior people, how many prior people have been exposed to this, for example? And is this the right time for me at my disease trajectory to think about being in this? So to do that, I recommend identifying your needs. Is there anything in your disease, in your care, that's not going well? And are there open trials that you should consider? What phase is the study? And what are the endpoints? What are they seeking to prove with this study? Are they seeking to prove that people feel better, that they live longer? Will I be able to contribute to that endpoint in the way that my disease is right now? There is a national, actually an international database that is open to everybody. It's called clinicaltrials.gov. And by searching that clinical trial and plugging in essential thrombocytosis, for example, or essential thrombocythemia, you can actually find the trials that are open on ET and where they're open. In fact, some of the physicians in this room are the investigators for those, so you'll see their names on there. You can contact them by email and say, is this a trial that would be open for somebody like me? Is there somebody I should talk to it about? So what if you find a trial? What does it take to join? Well, the first thing is you go through an informed consent process. An informed consent is a document which you read over that shows you some of the risks that might be associated with being in this. But informed consent is more than just signing a document. Informed consent is a patient and a physician sitting down one-on-one and having a true conversation about whether or not this is the right time for them to be in a trial and whether or not this is the right trial for them. And informed consent is a process. It doesn't end when you sign that document. You continue to go back to your physician. Ought I still be in this? Is this still the right thing for me to do? I've noticed this. It's a process to be completed. Once you sign that document, then you're screened, and that allows us to understand whether or not this trial eligibility criteria is met by your particular health condition at the time. Sometimes you go through screening and there's something that's not going to fit, and so then you're not allowed to be in the clinical trial. That doesn't mean you can't be in the clinical trial in the future if things change. But the clinical trial is restricted to a number of people that meet something called eligibility. If that happens, then you're enrolled, and sometimes there's a randomization, meaning if there's more than one arm of the trial, you'll be on one arm versus the other, and sometimes there's not. And then you begin the intervention, during which you're monitored for safety. Sometimes the dose has to be adjusted. Any kind of side effects or adverse events that you have are reported. You come off the study either when the drug is no longer being studied. Sometimes the clinical trials close because it doesn't work in a lot of people, even if it's working in you. And then you're off that study. Sometimes it's because your disease doesn't respond to the trial medication or intervention as was expected. And then that's the end of study. So as I said, informed consent is a process. It's about disclosing information. It's about making sure that it's understandable, that you have the ability to say yes, and that it's voluntary. And in the informed consent process, you go through exactly how the trial will be conducted, what your rights are, what you would do if you weren't on that trial, for example, what medications are paid for and what are not. And again, there's a lot of emphasis on the fact that the participation is voluntary. So moving into a clinical trial is part of a kind of a relationship that you build with your physician, the person who puts you on that trial, but also with the people that have designed that trial, which may be your physician, it may be the Food and Drug, or it may be the NIH, for example, or it might be a company that's trying to understand the effects of their intervention. It can be pretty confusing, and so you want to make sure that you have time to go through it and that you have somebody who's patient enough to go through it with you. The screening, as I said, happens after informed consent, and the eligibility criteria for being in the trial are reviewed by the investigator and make sure that you meet that eligibility criteria. You may go through some processes during that period of time, a bone marrow biopsy or extra lab tests, to make sure that when you are entered that trial, that you are considered enrolled in a way that's appropriate and that is not going to put you in danger. And then once you're on that trial, you go through the treatment and you might get a little map. Well, I have to be there on the first day and the 8th day and the 15th day, and I'm going to have labs drawn. And you should ask for a calendar when you meet with the investigator. What would it look like if I was on this trial? How often would I have to come here? Who pays for the parking if I have to come 4 times more than I would otherwise? Who's going to pay for my travel? Do I stay locally? Do I have to be hospitalized or not? All those are logistical questions that are very important to ask as you're going through this screening and informed consent. And then once you're on the trial, you have things that you would normally have, a physical examination, a history, for example. Trial results or standard of care results might be done. We record abnormal things, and then we adjust the drug Just like if you were not on a trial and you were on a medication and you developed a side effect, I might lower the dose, or if it's not working well enough, I might increase the dose. And those sort of things can happen on a clinical trial as well. And at the end of the treatment, you have to, if you've completed all the time on study, then there may be, that may be time for you to come off of it. Sometimes the disease progresses and you have to come off of it. Sometimes there's toxicities that are too concerning. You have to stop it. Sometimes you can come off the trial just if you decide to. This isn't a contract. You're allowed to stop any time as long as you and your physician discuss it. Sometimes there's a follow-up visit that needs to happen. So I would say that when you're thinking about clinical trials, you want to really carefully review the consent form. It's no good to just say, you know, doctor, I trust you. If you think this is the right thing, I'll sign on the dotted line. Because this is a bi-directional relationship, and you have to understand what you're interacting with. And you want to clarify all your medications. You want to make sure that you're informing everybody of new symptoms. You want to contact and partner with friends and family for support. And you want to keep track of what happens like a diary. Like I mentioned, you want to talk about financial considerations, what's paid for by my insurance, is there travel and lodging paid for? And you want to ask about certain phrases that might be confusing. Phrases like open label, which means you'll know what you're getting, you're not going to be blinded. Phrases like placebo-controlled, which means that there's maybe you might get the real pill or you might get a placebo pill and you might not know which is which. Phrases like crossover design, which means if it's a two-arm trial and the interventions arm that you're on doesn't work, you're allowed to move to the other one. That's called a crossover. So you want to make sure you clarify and ask those kind of questions, and don't be embarrassed if you don't understand what a phrase means. Lots of times I don't either, and just sitting down and talking it through can really make sure that this is the right trial for you. There's lots of resources. Like I said, there's your local hematologist, there's this clinicaltrials.gov, and all of us here are more than happy to talk to you about some of the trial resources that are available. So anyway, I just want to thank Anne for inviting me, Jason Gottlieb, who originally had this talk and who I've worked on it with him before. And I also want to thank you for all the work that you've done to make this disease much differently treated than it was 10 years ago. So thank you.
Any questions for Dr. Michaelis right now? So I'd have a question. So we hear a lot from patients that just are faced with lots of challenges and obstacles to participate in a clinical trial. And how do you mitigate that when you're discussing it with your patients?
So the obstacles include, so sometimes the obstacles are built into the trial, that the characteristics that need to be in place before you enter the trial are too complicated or difficult. Maybe your spleen has to be more than 5 centimeters but less than 17 centimeters, or your platelets have to be over the number 75. So one of the things that many of us who are working in the community are trying to do is making sure that the qualifications to enter a trial are as broad as possible. The other thing that's important is to really be very clear about why a trial might not be possible, and so we could try and figure that out. I had a patient who was eligible for a new trial. She lived in the northern part of Wisconsin. The trial was open at the Cleveland Clinic, and she needed to be on that trial and was medically fit to be on that trial. But the travel was too much, and her husband had a cardiac event and couldn't help her come down. Now, that's a real loss because this is a rare condition, a trial that she was eligible for, and we just couldn't make the travel work. But luckily, we were able to find a new opportunity where she could be on a trial at a similar trial at a different institution where she had relatives, for example, so she could stay with those relatives near the trial headquarters. So I think part of it is really spending the time to get to the real details of why can't you go. The other thing to think about is, are there ways that we should, as physicians, better discuss clinical trials with people, bringing it up on a regular basis, making sure that we not only know about the trials open at our institution, but at neighboring institutions, so that we're maximizing everybody in the community's opportunity to be on them.
Yes, geography, finances, I mean, there are just so many things, but there are resources available if you call us, if you're interested in a trial. There are some resources available.
I just have a question about when you are looking at trials where you have to travel, is there a typical kind of, because I've been on that website, nothing comes up for me right now, but what is the screening? If I have to go to LA from Boston, for example, what would I expect in terms of how often, how frequently you have to travel?
Yeah, so those are great questions. So first off, the Food and Drug Administration has instituted some rules that allow a lot more remote visits for certain things for trials ever since the pandemic. So the first thing is to have a conversation with the clinical trial coordinator or somebody that you might find through that website. Each trial has different requirements for in-person versus remote and how often you'd have to be there. But you might just say, could I do all my screening remotely? Will you allow local labs for certain things? Do you need a central review of my CT scan for my abdomen, or do I have to come and do it at a certain machine there? And as I say, the clinical trial coordinators or the physicians should be able to give you like a calendar, and that calendar can outline these have to be in person versus these can be remote or done locally. The other thing, and Anne mentioned it, is there are grants for travel for clinical trials that you can get through certain organizations. So you might have, 50% of your local stay reimbursed, or you might be able to get travel reimbursements to be on clinical trials. And some of the trials also pay for travel, or they might pay mileage, they might pay part of the local stays. There's some restrictions on rewarding people for being in clinical trials, because we don't want to incentivize people in a way that could drive people to be in clinical trials where it might not be in their best interest.